Get started. I know folks are still coming in. Hopefully, we don't run out of seats. Just want to welcome everyone to the State House. I want to call this voting meeting of the House and Labor Industry Committee to order. Jonathan, can you take the roll?
Dawkins.
Here.
Boyd. Brennan. Deloso.
Here.
Donahue.
Here by designation.
Giral. Green.
Here by designation.
Haddock.
Here by designation.
McNeil. O'Mara. Pisitano. Rozzi.
Here by designation.
Scott.
Here by designation.
Young. McKenzie.
Here.
Cooper.
Here by designation.
Diorsi.
Here.
Ecker.
By designation.
Flood.
Here.
Gleim. Ham.
Here by designation.
Jones.
Here by designation.
Kiefer.
Here by designation.
Rowe. Stambaugh. Here. We have a quorum.
Thank you. Today we have one item on the agenda, House Bill 2247, printer's number 3010, sponsored by Representative Kruger. Is there a motion? Representative Young makes a motion. Second by Representative, I'm sorry, Jarrell. I'm looking at Jarrell and thinking about someone else. Sorry. Thank you. Ryan, please explain the bill.
House Bill 2247, printer's number 3010, the Healthcare Workplace Violence Prevention Act, requires the creation of violence prevention committees and plans in health facilities, provides protections against retaliation for reporting an incident of workplace violence, and provides powers to the Department of Labor and Industry for enforcement.
Thank you. Thank you. I would now like to recognize the prime sponsor of House Bill 2247, Representative Kruger, for brief remarks on the bill.
Good morning, everyone. Thank you so much to Chairman Dawkins, Chairman McKenzie, and the other members of the House Labor and Industry Committee. I thank you for considering House Bill 2247 today. This vote is a long time coming. I've introduced a version of this bill every session since 2019, and before me, there were Democratic and Republican prime sponsors in the House and Senate of similar legislation every year since 2011. Workplace violence against healthcare workers is not new, but today, finally, we have a chance to do something about it. Every member of this committee should have received an 11-page document yesterday filled with first-hand accounts from frontline healthcare workers here in Pennsylvania about violent incidences that they have experienced on the job. If you haven't had a chance yet to read their stories, please do. They include graphic accounts of physical assault, including some injuries that were so severe that they ended the careers of the healthcare professionals involved. I wish these stories were anomalies, but they're not. According to the U.S. Bureau of Labor Statistics, healthcare workers accounted for 73% of all non-fatal workplace injuries and illnesses due to violence in 2018, which is the most recent data on file. And they are 5 times more likely to be punched, bitten, beaten, choked, and assaulted on the job than any other worker. PASNAP is a union that represents more than 10,000 nurses and healthcare professionals across Pennsylvania, and many of their members have joined us in this room today, along with members from the Pennsylvania State Nurses Association and SEIU Healthcare. The 2024 PASNAP member survey shows just how prevalent workplace violence is. 66% of respondents said they have experienced workplace violence, and 72% of respondents don't believe that their hospital or facility does a good job of protecting them from workplace violence. Right now, there is no current state law in Pennsylvania providing for workplace response and prevention efforts by health facilities. No current state law. This bill, House Bill 2247, finally establishes violence prevention committees and gives frontline healthcare workers a seat at the table as they work together with management to develop a written workplace violence prevention plan. This bill creates training requirements for health facility employees at risk for violence. This bill creates reporting requirements for incidents of workplace violence and creates the possibility of fines and penalties for facilities that are found to be consistent bad actors. Some hospitals, nursing homes, and home care agencies may have told you that they're already following workplace violence guidelines. That's great. Then they shouldn't have any problems following the provisions in this bill. We wrote it based on OSHA guidelines for preventing workplace violence for healthcare workers and included the 5 components of their guidelines in simplified form. But The OSHA guidelines are voluntary, not mandatory. So this bill codifies what we already know are best practices. This week is Nurses Week. So many politicians will make an effort to express their gratitude for nurses through speeches, social media posts, and even site visits. Today, we have a chance to give our nurses and other frontline healthcare workers what they are really asking for: a process to prevent workplace violence from happening in the first place, and a true process for reporting, investigation, and accountability when it does happen. Please join me in voting with nurses today and vote yes on House Bill 2247.
Thank you. Minority Chairman McKenzie will be offering an amendment, A04323. John, please explain the amendment.
Amendment A04323, Chairman McKenzie, makes comprehensive changes to the bill, moves enforcement of the act to the Department of Health, removes the existing requirements of the bill, and inserts new requirements that allow employees to make reports of workplace violence to the health facility or to law enforcement, and requires health facilities to take specific actions upon receiving a report, prohibits retaliation against an employee who makes a report of or against the victim of workplace violence, provides a grading enhancement for criminal offenses that constitute workplace violence, and requires signage at the facility entrance. It requires an annual workplace violence notice to employees, which will include information on the reports of workplace violence received by the health facility, information on the provisions of this act, that a violation of the act can be reported to the Department of Health, and contact information to report such a violation, that the general duty clause of the Federal Occupational Safety and Health Act requires workplaces to be free of recognized hazards, and contact information for OSHA to report such hazards. It provides civil immunity for a health facility, employees of the health facility, and security officers for actions in defense or protections of employees from workplace violence, and it provides that a violation of the act will constitute a violation of Chapter 8 of the Healthcare Facilities Act.
Thank you. Representative Gleim makes a motion to adopt Amendment A04323, second by Representative Stanball. I now recognize the Minority Chairman.
Thank you, Mr. Chairman, and thank you to the sponsor of this bill. As somebody who has been in and out of healthcare facilities quite a bit recently, I had the birth of a child a month ago. I also have a father who is undergoing cancer treatment right now, and I've been in a number of facilities, a number of different health networks, and seen that there is no standard across the board. You see variations in signage, you see variations in protocols that are listed. I have a lot of time sometimes standing around reading all those different posters that are on the wall that are meant to be for employees or for patients. And you can see that there is a lack of standardization there. And we do know, and I think the sponsor properly recognized the problem that is going on in the healthcare facilities. We know that violence is an issue in these workplaces, not just from anecdotal evidence, but also evidence that the state has. We can see in aggregate the severity of this issue all across the Commonwealth. I'll speak later on the bill, but specifically to my amendment. We feel that, first of all, I think that what we do in state government, there are a lot of outside folks, so I'm going to be speaking to the audience today. What we do in state government is intentionally meant to be a deliberative process, and it is also, in Pennsylvania, deliberately laid out by the voters right now to be a bipartisan process. So we have a Republican-controlled House, a Democrat-controlled House, a Republican-controlled Senate, and a Democrat governor. To make it all the way through that process, we need bipartisan buy-in and input. We were never consulted as the minority party on this legislation. We have never been consulted. We have not had any opportunity to weigh in until today, and so I have offered an amendment to this legislation to totally change the bill. I'll acknowledge that, but I think it is a much better approach. So walking through that process instead of what is in this legislation, which is merely a committee. A committee is great, but we all know that then the implementation of those rules are going to be left up to your employers. That may or may not happen. Just the mere creation of a committee does not give you the protections if somebody needs to intervene on your behalf against somebody who's violent. We hear all too often that the security guards, who are sometimes outside employees, feel that they can't step in because they might get in trouble. They might lose their job if they're in a situation where they have to restrain somebody or do something in that situation. So the protections that we're looking for are not housed in this bill. And so while I'm offering an amendment, and what you're going to see happen here today is Republicans are going to vote for this amendment because this is our initial offer. Democrats are going to vote against it. Then on the bill, it's going to be the reverse. Ultimately, what should happen is we should all come together so that we can find a solution that works for all of you and something that will actually get through that legislative process, actually become law here in Pennsylvania, and actually ultimately help healthcare workers. So I will say that this amendment that I have offered here, I think is a much better approach. But at the end of the day, I look forward to working with the prime sponsor, the minority chair, and others so that we can come to a conclusion that does have bipartisan support to help all of you in the profession. Thank you, Mr. Chair.
Thank you. Representative Young.
Thank you so much. I just have a comment and a question. I did hear Rep. Kruger say that she's been trying to offer such legislation since 2019, and I know that to the minority chairman's point, the Dems have taken over the House just recently. So I do believe there was a lot of time to discuss the information that is in this legislation. And what I also heard, and correct me if I misunderstood, the reason why there might be opposition to the proposed legislation is simply because of the lack of notification of what is going on in this piece of legislation. And so is it my understanding that the reason why our counterparts on the other side of the aisle might vote no simply because they weren't given information about this proposed legislation that apparently has been going on since 2019?
I can answer that. Sure. Thank you, Mr. Chair. So those are two separate issues. So this legislation, for everybody in the audience, their knowledge, it was introduced on April 29th, so very recently. So that is when this bill was particularly introduced. That would then put it on our radar so that we would know this piece of legislation may be coming up. At that point, that's when you would actually start having stakeholder meetings with people in your community. You would talk to all different individuals in the industry and try to get input to weigh in on an amendment. So that is this particular piece of legislation. I have not checked. I will trust the prime sponsor that it has been a concept or an issue that has been around for a long time. We are now in a situation, I was not chair before of this committee, neither was the majority chair. So we are both new to this position, and what would be the typical protocol would be that if somebody was serious about legislation and they actually wanted to introduce it, they would come around and they would speak to you about that legislation. They would speak to you about what your ideas are. Ultimately, the majority will have its say here. They will vote the legislation out that they want. That is not the best practice to advance legislation on such a serious topic. You would typically consult other people that are going to be involved in that process, even if for nothing else but just a mere, polite courtesy. You would say, this is what I'm looking to do, and I want to get your help or support on this topic. It's something serious. Again, I mentioned that I recognize the severity of this issue. We want to do something to help healthcare workers. The way to do that is to work together.
Thank you so much. I'm sorry, I don't want to cut you off, but I am, only because you emphasize that point a lot, and that's great. However, we've been here for a while, and this is not new legislation. I think the details that is outlined in this bill has been very congruent over the years. There's nothing new. You're right, you're a new chair, but you're not a new legislator. And when the R's were in majority for several years, there's been several opportunities for these type of legislation to pass. So I'm a no on the amendment, and I'm a yes on the bill.
Thank you. Representative Boyd.
Thank you. I just wanted to, ask a question that may be obvious, but because the minority chair wanted to make sure that the people in the room understood, your amendment removes the prevention part of this legislation, right? That it would remove anyone who works in a hospital who has the opportunity to discuss and be part of the prevention process. You are taking that out, increasing penalties. So if you've been bit, hit, hurt, you have your person who may have done that to you I'm sure was thinking about the penalties of what they were going to have at the end of their assault, would be the only thing that would be changing with your amendment, in that you would be removing the ability of the nurses to be able to be part of the prevention of their own violence.
That's incorrect. So if you'd like, I can go back through all of the additional points in our amendment. So we feel that there should be proper signage so that individuals are notified when they enter a healthcare facility, because I have seen some healthcare facilities have that signage, some do not. Some have very clear pop-up signs when you walk in saying that violence is not allowed in this facility, firearms are not allowed in this facility. You are given proper notice the moment you walk in that door, what is it allowed and what is not allowed in that situation. We also increase the penalties, as you rightly pointed out. If somebody is going to commit violence against an individual, we do want to make sure that there are proper punishments. We have also made sure that there is adequate reporting of all incidents. We made sure that there is, from the bill, anti-retaliation provisions put in the bill so that all individuals can properly report this to their healthcare facility. We also made sure that when those things are reported, then that information is transmitted out to all the employees of the healthcare facility so that then, as many of you are in a union, your union can go to your employer with all of the information. They will not be able to hide information from employees anymore about what is going on in these healthcare facilities. Your union can then say, we demand these changes. And this is what we see based on the data that is coming out. That is your voice at the table. That is why you are in a union. They are your advocate on your behalf in the healthcare facility situation that you're in. And then also, again, I mentioned providing civil immunity for not only the employees of these facilities, but security officers, so that when actions do occur, they have the ability to take appropriate and necessary steps. So again, I am wide open to discussion and conversation. If there are things that you think that we could do to make this amendment better, I am all ears on that. And I view this as two opening arguments in this debate. And unfortunately, this hasn't happened before this hearing. It should have happened before this hearing. But now there are two competing ideas. And again, hopefully we can reconcile those two things as this comes out of committee instead of just jamming it on a partisan line vote, which will ultimately die in the other chamber, as we've seen with so much legislation that has come out of this committee over the past year and a half.
Well, thank you. What I do hear is that your amendment would remove the ability of nurses to participate in the prevention of violence, so I'll be
That's
a no on the
incorrect.
amendment.
Thank you. Does anyone else want to be recognized on the amendment? All right, seeing none, let me just talk a little bit about this amendment and why I oppose this amendment. And we kind of heard some of it today from some of the members. Simply put, it just kind of removes some of the important provisions to protect those health care workers that we're here to protect from violence, and has the potential to automatically increase certain criminal penalties for people who are experiencing mental crisis. So for those reasons, I'm going to ask all our members to oppose this amendment. Jonathan, please take the roll.
Dawkins,
No.
Boyd, Brennan, Deloso, Donahue,
No by designation.
Jarrell, Green, Haddock,
No by designation.
McNeil, O'Mara, Piscitano, Rossi,
No by designation.
Scott,
No.
Young, McKenzie,
Yes.
Cooper,
Yes by designation.
Diorsi,
Yes.
Ecker,
Yes by designation.
Flood, Gleim, Ham,
Yes by designation.
Jones,
Yes by designation.
Kiefer,
Yes by designation.
Rowe, Stanball.
Yes.
The amendment fails.
Thank you. Is there any discussion on the bill? I now recognize the minority chairman.
I think I've spoken enough at this point, Mr. Chairman. Thank
Okay,
you.
no problem.
I will turn it over. We have two other members that are looking to speak on the bill.
Oh, what member? Oh, Representative Rowe.
Thank you, Mr. Chairman. I have just a couple of questions here on the bill itself. So on page 2, the bill provides for representation of non-managerial employees in the Violence Prevention Committee. And it states that the committee shall have proportional representation of union employees selected by their union and non-union employees elected by secret ballot by their peers. What happens if a healthcare facility doesn't have a union?
Representative, what lines are you on? This will be all clear.
So we're on page 2, line 23 of y'all's bill.
Okay. Got it. Thank you.
Yes, sir.
Representative Kruger, would you like to answer?
Yes, if you look at the line before it, it talks about the case of a facility that has no union representing its employees. That's lines 17 to 21.
Thank you.
Looks like a both and, not an either or clause to me. But we'll go ahead and we'll go to the next question then. So if we're looking at page 5, bottom of page 5 to be specific, top of page 6, the bill says that an employee reports the occurrence of an incident of workplace violence under subsection A may not be subject to discrimination, dismissal, discharge, or any other decision adverse to the employee. I understand and agree with the intent of what that language is trying to say. However, the way it is very broadly drafted means that under this language, if you make a report, you are now immune, meaning you could then be caught stealing narcotics. And under the language of the bill as written, you could not be disciplined for stealing drugs. Simply because, unfortunately, the language in the bill as written doesn't clearly define that the retaliation cannot be prevented from being against a staff or an employee who made a complaint based on workplace violence. It just says any retaliation for any reason. Unfortunately, Chairman McKenzie's amendment would have fixed that to clarify that you cannot be retaliated against simply for making a complaint. So I would ask if the chair, other members would be interested in entertaining an amendment on the floor, assuming this will pass today, to correct that language.
Representative Kruger?
Yes, so to your first question, retaliation specifically refers to subsection A, an employee who reports the occurrence of an incident of workplace violence. So the protections against discrimination, dismissal, discharge, or any other decision adverse to the employee directly refers back to section A. That is the incident we're responding to.
Okay, if we're, just really quickly though, it does not say then may not be subject to discrimination, dismissal, or discharge under subsection A. It simply says if you make a complaint under subsection A, you are immune to discipline, period. It doesn't clarify that discipline, discharge, dismissal has to be part of subsection A as well. It doesn't clarify that.
With all due respect, it doesn't need to.
Well, why not? I mean, I kind of think it does here, right? I mean, we don't want to be creating a carte blanche for anybody to do anything after they just make a report. Because this is about protecting employees, this is about protecting patients, this is about protecting institutions. We need to clarify before we start handing out immunity to people, because 99% of people who will need it for the right reason. And by allowing 1% of people who could abuse this simply because we are rushing a bill through the process, we're not having a hearing, it's introduced last week, it's rolling this week. These, just for everyone here, these are the kind of drafting errors that we correct through the legislative process. We have a sharing of ideas, we can sit down, we can avoid these unintended consequences, which is unfortunately what this drafting error has done. If we had had a hearing on the subject, if we had any bipartisan buy-in, these sort of things could be avoided. Unfortunately, the issues with this means we're either going to have to correct this on the floor, or we're going to have a bill that really doesn't do what it was supposed to do in the first place. So because this bill is clearly not ready for prime time, it needs some amendments. I'm going to have to be a no today, although I understand and appreciate. I'm looking forward to some amendments on the floor to get us to a yes. Thank you, Mr. Chairman.
And
Thank you.
Mr. Chairman, with all due respect, there are no drafting errors in this bill, in this clause. The establishment is clear in Section A. Each health facility shall establish a violence prevention committee to establish, review, administer, and provide guidance about a program related to the prevention of workplace violence in the health facility. The amendment that you just voted down struck out the violent prevention committees and did take away the voice of workers at the table. So thank you for opposing that amendment.
Thank you, Representative. Representative O'Mara.
Thank you, Mr. Chairman. Since everyone is addressing the audience, that's what I would like to do. And really, thank you. I would be lying if I didn't acknowledge that nurses have been in my office probably 2 times a year for the last 6 years advocating for this issue. And that's just as long as I've been in Harrisburg. So to say, for anyone to say that this is a new issue, that no one's approached you about it, no one's been polite enough to ask you about it is false. And so I want to just start off by thanking you for your continued advocacy and for continuing to do the job, even though we here in Harrisburg, and I won't say the Democrats because we've only just gotten to be in charge, have not showed up for you. Now is everyone's opportunity to vote yes on this bill and to show nurses that you stand with them and are going to work to prevent violence in their workplace. We started off with acknowledging that there isn't uniform application of this. So we can acknowledge that there's a problem, but try to play partisan politics to not support nurses. That is shameful and yet continues to happen in the Labor and Industry Committee by now the minority side. I have been on this committee for 4 years. And I know that Representative Kruger has asked for us to run this bill before. And now it's finally happening. So I would just want to correct the record a bit here and acknowledge your continued work and advocacy on this bill and thank Chairman Dawkins for moving such an important and necessary piece of legislation. Thank you, Mr. Chairman.
Thank you. Representative Gleim.
Thank you, Mr. Chairman. It is an important piece of legislation, and I have nurses in my family, and I want to get the legislation right. On page 6, line 22 through 23, the bill allows the Department of Labor and Industry to administratively order the payment of restitution to an employee. Then on page 7, the bill lists the relief that a court can order an employer to pay an employee. So although I disagree with the practice of creating a new civil right of action in almost every bill that moves through this committee, I think it's inappropriate to allow an administrative agency to order restitution to be paid to an employee. That language is confusing, and it allows employees to double dip in workers' comp claim injuries. I would like to see if we could possibly amend that language to make it more clear. That's my first request. The second is page 3, the beginning on line 9. The bill requires a risk assessment evaluation of the factors that may put an employee at risk, which I totally agree with. One of the factors must be evaluated, though, is working in a unit that does not have adequate employee staffing levels. The violence prevention committees must then create a violence prevention program to mitigate the risk based on the assessment. So if an evaluation found inadequate staffing, the program would then be required to mitigate that risk, and employers can be penalized or sued if they do not comply with the violence prevention program. So this sounds very similar to the nursing staff ratio bill, and that bill was controversial when it was passed earlier this session. So I would just like a little more clarification on that section. Page 3, line 9, please.
Sure.
Representative Kruger.
Yep, you have a number of questions, so let me address them in the order that you asked them in. So first of all, the administrative order on page 6, which allows a payment of restitution for the employee. The Department of Labor is the administrator for this bill because this is about working conditions. The Department of Health is not qualified to evaluate working conditions, but the Department of Labor is. And in fact, they already oversee the Mandatory Overtime Law, Act 102, as it applies to acute care hospitals. So they do have some precedent of overseeing working conditions. This expands that opportunity. Your next question on page 7, the court may enjoin. Enjoin simply means to stop. So a court may stop a health facility from engaging in illegal activities. That is the action of the court, and I hope we would all agree if we found a hospital or nursing home engaging in illegal activities, we would empower the court or support the court in stopping those illegal activities from happening. And then your last question on adequate employee staffing levels. I don't know that the folks in the room behind me would say that safe staffing is controversial. That is a bill that passed with bipartisan votes, with bipartisan, in fact, Republican prime sponsors on that bill. Yes, workplaces become more unsafe when safe staffing levels are not in practice, and so that is one of the recommendations actually that comes out of OSHA for workplace violence prevention, which is what this bill is about.
Okay, thank you. I have one follow-up
Sure.
question. Has the Department of Labor and Industry ever have they had experience in going into health facilities before? I'm just asking, like, is that part, do you really think that that's part of the Department of Labor's duties, or is that really the Health Department's
The
duties?
Department of Labor already oversees the mandatory overtime law, Act 102, as it applies to acute care hospitals. So yes, the Department of Labor
Overtime.
has experience going into acute care hospitals.
Okay, thank you, Mr. Chairman.
Thank you. Representative Brennan. Wave off. Minority Chairman.
Thank you, Mr. Chairman. So I will close with a couple personal items and then relating to the bill, and then on the specifics of the bill. So, as somebody who, my grandma was an RN for her career. My grandfather was a doctor. They both worked in healthcare facilities. And I think everybody on this panel here today recognizes the problem of violence in healthcare facilities. We have stated that. We have offered our proposal, which is obviously very different in a number of ways, but somewhat similar in a lot of ways as well. And what we have been met with is people impugning our character, trying to cause division in this room by saying we're on your side and they're not on your side, by people saying you don't understand what healthcare workers are going through. These kind of comments are what people hate about politics and what people hate about government. If you actually want to get something done in government, you have to work together. You guys know that in a healthcare environment that it is a collaborative team engagement that you're involved in. That's what we should be doing here today. But what you're hearing is opposition from members of this committee and taking personal shots at other people. What you're hearing from the prime sponsor is total intransigence to any input from members of this committee. So what we need to do is, again, come together. My office is open. We will have meetings. I will have meetings with individuals who actually want to come to a conclusion on this legislation. And if that is what we want to do, then we can do it. We have passed legislation through this House, through previous committees, that have actually helped workers in Pennsylvania. We have done that. We can do that again, and I have that hope for a brighter future than what we have seen here today and what we've seen throughout this session in this committee. Thank you, Mr. Chairman. I would urge a no vote and urge us to get back to the table on this legislation so that we can come together in a bipartisan fashion and work together with all of our colleagues to come to a conclusion that actually helps people and actually reduces health care violence in those workplaces. Thank you.
Thank you. Representative Piscatano.
Thank you, Mr. Chairman. This is the legislative process. We have members of the public, people affected by this legislation here in support or opposition. We have the prime sponsor sitting at that table, answering detailed questions line by line. She provided answers. Nobody, is obfuscating or skipping answers or refusing to answer questions. I think Representative Cougar should be commended for how she has sat here during this meeting and answered detailed, specific questions by members of the minority party. That's the legislative process. And the legislators up here can tell the members in the audience that we could find any reason to vote against a bill. I don't like a comma here and or, either or. I could find a million different reasons in any piece of legislation to vote no. But we're here to vote yes. We're here to solve problems. That's what the legislature should be doing. And so I think it's totally disingenuous for the minority chairman and the minority party members of this committee to sit over there and say, well, we support this, but we have problems with this, and we have the commas in the wrong place here, and we don't like how this is phrased, and nobody came to my office early enough for me to weigh in on this bill. This is how it's supposed to work. And you can vote yes here because you actually support the nurses in this room and want to help solve the problems that they have in their daily life every single day. Or you could vote no because you find some nitpick to vote no. That is your decision as a member of the legislature. But let's not act like that's how this is supposed to work. Other committees that I sit on that serve and solve problems go through these kind of discussions and say, and I've been in other committee meetings where other chairmen from the minority party will say, I'm not 100% there. I think there still needs to be some work on this bill. I have some questions or concerns, but I'm going to vote yes because I think this is an important issue and I want to stand up for the people that it respects. We don't see that in this committee. We find the minority party in this committee finds any little reason to say no, and then they go, oh, I'm not against it, but I have to vote no because I don't like where the comma is in this sentence. That's not how it works on other committees. It should not work that way on this committee, and I'll be a proud yes for this legislation. Thank you to Representative Kruger.
Thank you. Thank you. And let me thank the prime sponsor as well for introducing this important legislation, which we know will help protect our healthcare workers from violence in the workplace. But let me also share something with folks in the audience about the process. This is only the first step. We go through a committee process. Members can offer amendments in this process. Out of this process goes to the floor, where members can, again, offer amendments and discussions on that bill. When it leaves the House, it goes to the other side of the building to the Senate, where that process starts over in a committee. They can offer amendments, have a discussion. Goes to the Senate floor, where they can offer amendments, go through a process. And if they make changes in the Senate, it comes back to the House for us to have another discussion. So it is disingenuous to sit here and say that they didn't have an offer to make the bill better or we rushed the process. I've been here for 10 years. These bills came up under different legislators through those 10 years. Some were Republican, some were Democrat. We have not got this bill across the finish line, which we are trying to do. We have taken over the majority first time in 12 years. Last session, it was a Republican-ran committee, which the minority chair sat on. It was only 24 bills that came out through the entire legislative process. We started late and we got 24 today. Showed you that it's a different pace that we are moving in. So if it feels a little fast, I will tell the minority party to keep up, because this is what we're going to do. We're going to run legislation for workers. This is the labor committee, and we're going to do some laboring in this committee. So with that being said, I'm urging all members, R and D, to look out in the crowd and ask yourself, do you or do you not support a process of moving this legislation forward to continue to have a discussion? It does not mean your voices are not being heard. It does not mean the suggestions or comments you made have been overlooked. This is the first step. Are you willing to take a step? Jonathan, call the roll.
Dawkins.
Yes.
Boyd. Brennan. Deloso. Donahue.
Yes by designation.
Jarrell. Green. Haddock.
Yes by designation.
McNeil. O'Mara. Piscitano. Rozzi.
Yes by designation.
Scott.
Yes.
Young. McKenzie.
No.
Cooper. Diorsi. Ecker.
No by designation.
Flood. Gleim. Ham.
No by designation.
Jones.
No by designation.
Kiefer.
No by designation.
Rowe.
No by designation.
Stanbaugh.
No.
The bill passes.
Thank you. House Bill 2247 is reported as committed from the House and Labor Industry Committee. And there's no further business. This voting meeting is adjourned, and we will move forward for an informational hearing on the nursing workforce crisis. We're going to roll right into it. All right. Yep. So we're going to have folks transition, and folks want to leave. That's fine. You can do it now. I would like to call this informational hearing of the House and Labor Industry Committee to order, and I'm going to have Jonathan call the roll.
Dawkins.
Here.
Boyd. Brennan.
Okay.
Deloso.
Here.
Donahue.
Leave.
Thanks.
Jarrell. Green. Haddock.
Leave.
McNeil. O'Mara. Piscitano. Rozzi.
Leave.
Scott. Here. Young. McKenzie.
Here.
Cooper. Here. Diorsi. Ecker.
Here by designation, or leave slip.
Flood. Gleim.
Right here.
Ham.
Leave.
Jones.
Leave.
Kiefer.
Leave.
Rowe. Stanbaugh.
Here.
We have a quorum.
Thank you. So over the past few years, there has been a lot of attention that has been paid to healthcare workforce crisis that we are currently experiencing in Pennsylvania and nationally. However, the focus has mostly been on fixing the pipeline, little attention has been paid to retaining the workforce we already have. Today, during National Nurses Week, the committee will hear directly from 5 nurses from across the state about the factors that are causing nurses to leave the bedside. From nurses' perspective, what can be done to address the workforce crisis? The second panel includes experts who will discuss changes in the healthcare industry that have contributed to these challenging working conditions. And with that, I'm going to ask the minority chair if you want to make any comments.
No, I would just thank the chairman for holding a hearing on an important topic that is an important part of this process that we have missed many times before in this committee. So I thank you for doing that. This is a very important topic. Healthcare staffing throughout the field is something not only in recruitment but also in retention, as was pointed out, something that we need to focus on in this Commonwealth. I think this is a great topic to be discussing today because we do want to, again, we recognize the problem and we share in recognizing that problem. So now we need to come up with ways that we can improve this situation to help provide adequate and appropriate health care to all individuals across this Commonwealth. I want to thank all of the people that are here testifying today for the work that you do, and thank everybody in the audience for their work that you do on every given day to help people across our state, and look forward to the discussion. Thank you.
Thank you very much. And for the testifiers, I'm going to have you introduce yourself. And just know we kind of ran a little bit over on our voting meeting, but you now get to see the process live in action. So we got about 45 minutes before we are on the floor. So we'll try to make brief remarks, but try to make sure we get to the core of what this committee informational hearing is going to be about. So I will start with you, Michelle. You can introduce yourself, and we'll work through the table. And then once everyone has the introduction, we can run right into Maureen. You'll be the last one, so you'll start from there. Thank you.
I'm Michelle Boyle. I'm a 30-year nurse working on the floor at Allegheny General.
Jamie Balsamo from UPMC Altoona, have been a registered nurse for 16 years.
My name's Jennifer Mizell. I'm a registered nurse with UPMC. I've been a nurse for almost 2 decades.
Davey Shear. I'm an ER nurse in Philadelphia. I've been a nurse for almost 13 years.
And I'm the senior in here. My name is Maureen May. I've been a nurse for close to 39 years, and I work at Temple University Hospital, and I've been in direct care the whole time.
Thank you, Maureen. You can get started.
Thank you. Good morning. My name is Maureen May, and I've been a bedside nurse for over 38 years in critical care, maternal health, and now in the neonatal intensive care unit. I love what I do, and I am a proud nurse and proud to be a nurse. While I work at the bedside, I also serve as the president of PASNAP, the Pennsylvania Association of Staff Nurses and Allied Professionals, representing about 11,000 healthcare workers across the state. I would like to thank Chairman Dawkins and Chairman McKenzie and members of the House Labor and Industry Committee for allowing me to speak today about something really important, especially to bedside nurses and especially during Nurses Week. Many of you in the room have been told that there aren't enough nurses in the hospitals, or that the hospitals are trying and they just can't find nurses. I'm sure you've all heard that. I am here to give you a different perspective on the workforce crisis. While it is true that we need to expand our pipeline of nurses and work on providing more resources to get nurse educators into the system, the real problem is inside the hospitals. You can recruit nurses into the profession all you want, but if we do not fix the working conditions in the hospital, nurses by and large don't stay very long. As of last year, the Hospital and Health System Association of Pennsylvania cited that they had a 30% turnover rate for nurses in hospitals. That was the Hospital Association's very own data, and that was one of their reasons for opposing the Patient Safety Act. I've read that it's come down slightly to 28%, but retention remains a problem. Nurses still are not staying in the hospitals and at the bedside. Why is that? The problem is the working conditions. Between unacceptable staffing levels and escalations in workplace violence, nurses are finding other things to do with their licenses, or they are just simply retiring. We have enough nurses in the state of Pennsylvania, but they're sitting on the sidelines. They don't want to be subject to moral injury, risk their license, personal injuries, so they have decided to do other things. We can get them back. We can get them back to the bedside, but for that to happen, the working conditions must improve. I also want to thank the committee for today's consideration of the Health Care Workplace Violence Prevention Act, Bill 2247. I also would like to thank Representative Leanne Kruger and Representative Bridget Kozarowski for all of their work and leadership on this issue. The conversation about workplace violence in a healthcare setting has been long overdue and desperately needed. Our members have countless stories. When we talk about workplace violence, we're not referring to cases where the patient accidentally hits you or kicks you when they're coming out of anesthesia. And I've worked in PACU too, because I've been kicked and hit in coming out of anesthesia. We're talking about patients that have intentional violence that gives us pause. I know this hearing is not about House Bill 2247, but these topics are related. So I want to discuss it briefly. In any other profession, if someone were assaulted at work, it would be dealt with in the most serious manner, but for some reason in the healthcare field, particularly nursing, where the vast majority of the profession are women, workers are expected to absorb this violence, walk it off, and then they go home wondering, who's protecting me? Hospital management's response to countless cases of workplace violence is often less than adequate. We have examples, some which are truly horrific, and some which are not. However, in the city hospital that we are governed as a union, we have a tech that had their finger bitten off and spit across the room. The ER had to amputate the remaining part of the employee's finger. Regardless of the mental state of the patient, can we agree that that's unacceptable? In some hospitals, the security guards who respond are not allowed to touch the patient acting violently. What's the point of that scenario? Nurses are highly trained clinical professionals. We are not punching bags. We are not people who are willing to accept being stabbed, punched, bitten, pushed, shot, spit on, threatened, you name it. We have another example of a nurse that was punched in the face so severely she required reconstructive surgery, and then she will never return to work. Can we all agree that that's unacceptable? We have shared many of these examples, as said earlier, of these incidents to the committee. It happens everywhere, not just in the urban areas, suburban, but also in rural facilities. Now, violence is not the fault of the hospitals, but the lack of response, remediation, and preparation to ensure that we have hospital policies and procedures and the equipment to prevent workplace violence is the hospital's responsibility. It is their fault when the system breaks down. Employees are just asking for a seat at the table to discuss how to make their workplace safer. That's all, just to be part of the conversation and help design the procedures in order to prevent workplace violence. I want to thank the committee for advancing the discussion on workplace violence prevention in healthcare facilities. This is one important reason why the nursing workforce crisis is here. Hospitals need to do better. I want to mention that spikes in aggression and violence from patients and patient families occur more frequently when they are frustrated or their loved ones or themselves are not getting enough attention due to poor staffing. These issues are linked. Poor nurse staffing levels are the #1 reason why nurses are leaving. When you graduate from nursing school, you have a vision of what it is to be a nurse, and it's entirely different once you hit the floor and you're thrown into the deep end of the pool. And in some cases, throughout the Commonwealth of Pennsylvania, nurses are given 11 patients. Really, that is way too many patients. And it's not every hospital, but it is in many hospitals. And any number of patients over 4 is unsafe and leads to negative outcomes. If there are too many nurses, too many patients, nurses cannot catch the subtle signs, let alone the overt signs of a medical decline, and intervene in a timely manner. They call that failure to rescue. How would you see yourself if you had to decide which coding patients, which happens simultaneously? And it happens, I know. I'm a neonatal nurse and we resuscitate. I have to be in the ER, but then I'm told I need to be in labor and delivery at the same time. Where do you pick? How do you do that?
Thank you.
One last thing. Many of us drive home from work frustrated that we could not give the care that we needed to give. We want to give 100% care quality that is possible, the kind of care that any patient, anyone would want to give. But that's not happening. Hospitals don't like to hear this, but it's the case. Trying to staff hospital with the fewest nurses possible is sort of their business model and has been for years. The problem was even here before the pandemic, and we all know that, it's only gotten worse. Unfortunately, this issue is about hospitals and money. Many of you on the committee were in favor of House Bill 106 and on the House floor advanced the legislation for safe staffing last June. We thank you. We're not going to stop advocating for these issues. We hope we can get them across the finish line this year, but if time runs out, I guarantee we'll be back, because it's too important to give up on these vital pieces of legislation that impact the bedside. I'll leave you with one last note. Thank you for holding this hearing during Nurses Week, because the discussion about nursing workforce crisis doesn't often include the bedside nurses. Hospital administration and nurse managers are discussing this in the halls of Harrisburg, but the bedside nurses have been pretty much left out of the problem, and we know what to do and how to correct it. I'm sure you will hear from the Hospital Association and other hospital networks about how they don't like the Healthcare Workplace Violence Prevention Act. For one reason or another, I don't understand that. You've heard opposition to the safe staffing bill. We don't understand that either. But at the end of the day, what the hospitals and health systems are saying to us is that we want to keep the status quo, and that the bedside nurses and professionals are saying to you right now, we are saying to you that the status quo is not acceptable and not sustainable. Thank you.
Thank you. Next, we have Jamie. Oh, you want to go to? Okay, sorry, Jamie.
Yeah.
Sorry.
Hello again. I want to thank the committee members as well for holding this during Nurses Week. Again, my name is Jamie. I've been a registered nurse for 16 years, all of that time being at UPMC Altoona. I have deep-rooted dedication to Altoona because it's always been my family's and my community's hospital. I was born there. My son was born there. Every member of my family has received care there over the years. But I'm saddened to say, since UPMC took us over 10 years ago, Altoona has become a shell of what it used to be. We've watched our hospital's priorities go from focus on patients to focus solely on numbers. Frontline healthcare workers no longer feel heard. We're treated as if our opinions don't matter, and we're not cared about at all. The only thing that matters to UPMC corporate is how much work they can squeeze out of us with fewer and fewer resources. I'm an example of the burnout and mass exodus away from the bedside that is plaguing our healthcare workforce. For the past 3 years, I worked in the intensive care unit, which is where my passion truly lies. But about 4 months ago, I transferred out of the ICU to the cardiac catheterization lab in order to avoid leaving the hospital altogether. I just couldn't survive any longer in the ICU due to the working conditions, and I could no longer ethically accept the risks that my patients were facing. Because of the fragile health of intensive care patients, nurses should not have more than 2 patients each, according to Altoona's own staffing guidelines, but ICU nurses at Altoona regularly have 3, which violates these staffing guidelines and does not ensure the quality of care patients deserve. Sometimes, well, often, I would be assigned as the charge nurse who shouldn't have any patients of their own, and I also carried a pager to respond to emergencies throughout the hospital, forcing me to leave my own critically ill patient sides to attend to other critical patients in other departments. On our medical surgical floors, nurses shouldn't have more than 5 or 6 patients ever to safeguard quality care, but ours often have 8. This makes it almost impossible to deliver the quality of care that we believe in, and leads to a sense of defeat and moral injury. Moral injury is when nurses' core values are violated by our lived experience. Every day I worked in the ICU, and I would wake up and say to myself, I can't do this anymore. It's gotten so bad that our patients have started to speak out as well. Recently, there has been a flood of letters to the editor in our local newspaper by patients describing their experiences there. We have a strong union at Altoona, SEIU Healthcare Pennsylvania, which provides us with more rights than non-union UPMC workers, but our union only represents a fraction of UPMC's 100,000 employees, making it hard to create the changes that we desperately need in the system. That's why we need our elected representatives to create and enforce standards throughout our Commonwealth's healthcare system to protect our patients, our communities, and our frontline workers. Thank you for being here today.
Thank you. Next, we have David.
I'd be quick. Thank you, Chairman Dawkins, Chairman McKenzie, and members of the Labor Industry Committee. My name is Davey Shear. I'm here to represent the Pennsylvania State Nurses Association, where I'm the chair of the Government Relations Committee. I'm a registered nurse with nearly 13 years of clinical experience in both emergency and critical care nursing. I'm deeply passionate about the critical issues of nurse staffing, specifically the utilization of ratios. I'm a non-union nurse, and I believe that nurse staffing ratios are needed in both union and non-union hospitals for the well-being of patients and nurses alike. The current situation for many direct care nurses is all too familiar for many of us still working at the bedside. Picture a bustling hospital emergency department filled with patients requiring varying degrees of care. The nurses are stretched thin, navigating the demands of multiple patients concurrently. Time's an amenity that most of us don't have. The pressures are so immense to provide the optimal care while adhering to the necessary standards of care that we've been trained to do. In this setting, nurse staffing ratios become more than mere numbers or spreadsheets. They connect patient safety and quality of care. When nurses are assigned too many patients to handle, that situation not only endangers the well-being of those under our care, but also places an unbearable burden on the shoulders of nurses themselves. We become susceptible to intense fatigue and stress. Under these prolonged conditions, it's impossible to provide the level of care that our patients require and that we want to give. I've had firsthand experience navigating through shifts when the nurse-to-patient ratio was not ideal. It's a constant battle to prioritize tasks, administer meds on time, respond to emergencies promptly, and still find those needed moments to offer comforting words or supportive smiles to the patients and their families. It's emotionally and physically draining, and it takes a toll not only on individual nurses, but on the entire healthcare system. Some may argue that implementing strict nurse staffing ratios could strain hospital budgets, including non-unionized hospitals and non-unionized settings, where negotiations might be more challenging. But investing in adequate staffing levels is not just a matter of fiscal responsibility, it's an ethical obligation that must be upheld. The data from the University of Pennsylvania's Dr. Linda Aiken, the leading researcher on this subject matter, has consistently shown the benefits of nurse staffing ratios. The implementation and success of staffing ratios in California and the push for ratios elsewhere are building momentum across the nation, including our own Commonwealth. This research, backed by years of peer-reviewed studies, should be a catalyst for health systems to bring ratios into utilization nationwide. Unfortunately, seeds of doubt have been spread amid suggestions that ratios will hinder the solvency and well-being of hospitals. These suggestions fly in the face of data showing otherwise. When hospitals fail to recognize patient safety and staff well-being, everyone suffers. Studies have repeatedly shown the higher nurse-to-patient ratios are associated with higher rates of adverse effects, including medication errors, patient falls, and even mortality rates. Also, when nurses are not overburdened with undue workloads, they can provide the compassionate, data-driven, and holistic care that defines our professions and for which we are known. The issue at hand is not just about numbers on balance sheets. Rather, it's about the lives we touch and the trust that our patients place in us during their most vulnerable moments. As nurses, we are advocates for our patients. We're their voices when they cannot speak for themselves. We owe it to our patients, ourselves, this Commonwealth, this nation, to ensure that nurse staffing ratios reflect the level of care and compassion we strive to deliver every day. And I'll end with this. For several years, we've heard about a nursing shortage. That's a misnomer. Rather, there's a workforce crisis. Specifically, thousands of highly qualified and experienced clinical nurses are leaving the bedside. They leave instead of subjecting themselves to the continued overexertion and the stressful and unrealistic situations that make up today's bedside nursing experience. If hospitals want more bedside nurses, which is what the data shows, and they do indeed want, then the onus is on the hospitals to ensure a safe clinical and work environment to attract and recruit nurses and to bring them back to the bedside. It truly is that simple. Thank you for allowing me to testify before you today. I look forward to any questions. Thank you again.
Thank you very much. Next, we'll have Jennifer.
Hello, and thank you to all of the committee members. Okay. My name is Jennifer Mizell, and I've been a registered nurse at UPMC for almost 2 decades. I became a nurse because I wanted to make a real difference in people's lives. That's what's kept me going through all of these years, especially through the trauma of the pandemic. But as UPMC has consolidated more and more power, staffing levels have been eroded, and treatment of nurses has worsened, making it increasingly difficult to deliver the safe care our patients deserve. For close to 2 years now, I've been part of UPMC's travel staffing program. This experience has given me an overview of the severe challenges nurses are facing throughout the UPMC system. Currently, I'm assigned to the post-anesthesia care unit at Carlisle. And one of the most troubling examples of understaffing that I've experienced, UPMC does not consistently follow the staffing guidelines set by the American Society of Peri-Anesthesia Nurses. Those safeguards specify that recovery room nurses should each have 1 to 2 patients who have just come out of surgery and are recovering from anesthesia, and that there should always be at least 2 registered nurses in the room. That's because patients recovering from anesthesia and coming out of surgery are incredibly vulnerable and need a high level of personal attention. But there are facilities I've worked at within the UPMC system, including Carlisle, where at times recovery room nurses are each responsible for 3 patients that came out of surgery, contrary to the ASPAN staffing guidelines. On weekends and in the evenings, some UPMC facilities where I've worked often have only 1 nurse in the recovery room, despite the ASPAN guidelines stating there should be 2 nurses present at all times. When there's only 1 nurse, if a patient goes into cardiac arrest or can't breathe, we have no backup. There's a saying in healthcare that time is brain, time is heart. Every second counts to save a patient's life. When you're alone, you're faced with an excruciating choice. Do I start CPR first? Do I get the crash cart with defibrillators? Or do I call for help? I cannot do all 3 at once. On top of the extreme understaffing and exhaustion, UPMC executives recently cut internal travel nursing pay by $13 an hour. We signed up for the Traveler program and made deep personal sacrifices, including time away from our children and our family, to help UPMC. Our hospitals are still dealing with the effects of the pandemic, turnover, burnout, exhaustion, and bedside nursing shortages. Our patients are sicker and need more care than ever. The hospital industry is calling on the state government to bring more nurses to the bedside, but instead of solving this crisis, UPMC executives are doing the exact opposite, and they're driving nurses away. We need elected officials to stand by our side, hold UPMC and other big health systems accountable, and ensure safe, quality care for the people of our Commonwealth. Thank you.
Thank you. Michelle?
Hi, I'm Michelle Boyle. I'm a union nurse at Allegheny General. Nursing is one of the most rewarding jobs where I can contribute to the well-being of my patients. In the most difficult and darkest hours for a person, nurses are present, as you've heard today, to help patients through their healing and provide dignity when patients feel they're most vulnerable. When I started in nursing, I expected stressful situations. We all did. Over the past 3 decades, however, healthcare has gone from stressful to traumatizing as corporatized healthcare has taken over. Big corporations' relentless push towards a consolidation of market power, decimating frontline staffing, suppressing wages, and excluding frontline healthcare workers' voices from patient care decisions has created traumatizing conditions for both nurses and patients. Due to traumatizing conditions, nurses are leaving in droves. Up to 50% of new nurses leave their first job within 3 years, and 60% within 8 years. We have licensed nurses, but they are not willing to work in traumatizing conditions. There are over 81,000 licensed registered nurses in the state of Pennsylvania who are not currently employed in healthcare. At AGH, we fought to have a voice to address this crisis because we are strong union nurses with SEIU Healthcare PA. In our latest union contract, we improved staffing ratios that are unparalleled in our Commonwealth. Numeric ratios that also take into account the acuity of our patients to ensure safe care. To help bring nurses in the door, we raised the starting wage by nearly 30% to $40 an hour. And to retain nurses, we negotiated overall raises of as much as 29%. We defended our 100% covered premiums, decreased our copays for mental health visits to $5, and defended our pension. We want all nurses to enjoy the same standards. Unfortunately, the vast majority of Pennsylvania's 140,000 nurses are not yet union and struggling in extreme traumatizing conditions without a voice on the job, as you've heard. That's why we need legislative and protective standards like the Patient Safety Act to hold the corporate healthcare systems accountable. We can win it in our contract, but if it's not a law, the market pressure about our ratios, we are having to defend day in and day out. And we need elected officials to step up to ensure that more nurses and healthcare workers have the ability to organize and bargain for better standards in their hospitals and nursing homes for their patients and themselves. We are on the front line. We know what's needed. The majority of money that flows into our healthcare system comes directly from taxpayers. Taxpayers, Medicare and Medicaid. There is no reason we should continue to allow the healthcare industry to lower patient standards for our friends and family by denying healthcare workers a voice. The suits who created this crisis, they aren't fixing it. The frontline healthcare workers, we know we didn't break it, but we're patient care advocates. And we sure as heck will show up at every opportunity to fix it. We need your help. Patients need more people in scrubs and less in suits. Thank you.
Thank you all for your testimony. I'm going to open it up for some questions. You have a question? Go ahead.
Well, thank you all for your testimony here today, and I hope your employers were listening and watching, because what I heard here today is very concerning. And, you know, I'm not going to stand here in defense of the large corporate health networks. I, again, personally, my family and others in my extended family have received inadequate care at these facilities. And when we have complained about it, nothing was done. Nothing was done to change the situation where people were given very significantly adverse care that impacted them in their lives. And they'll try to offer you settlements as a patient if something goes wrong. They'll try to dust it under the rug. We know that this is going on. And so thank you, as workers, for standing up and offering your voice here today. We do want to help you in this process. And, you know, I think I've just seen during my lifetime, I've been a legislator for 12 years, but longer than that, the consolidation which has happened in the healthcare industry is not leading to better outcomes for patients. It is not leading to longer life expectancy as a country. And you are correct that that has been driven by the federal government coming out of Obamacare. They have incentivized and they have pushed the consolidation. You shrugged your face there for a second. I'll give you an example. I mean, all of the reimbursement structures are incentivizing healthcare networks to consolidate. All of the back-end costs of digitizing medical records made it impossible for smaller facilities and independent doctors to actually do that and to actually compete. So all of that forced that consolidation. That is a well-known fact that consolidation has been going on in this industry driven by federal government policy. And we are now on the flip side of that. We are seeing what happens when you give too much power to consolidated entities. Workers are on the losing end, patients are on the losing end, and we need to do something about it. So again, we should be recognizing the problem, and we should also be coming up with solutions to work together in a bipartisan fashion to help workers and help patients. So thank you for coming here today. I appreciate your testimony and look forward to continuing this conversation with other stakeholders as well. Thank you.
Representative Brennan. Yeah.
I'm sorry. This is for Michelle Boyle. How has having a union made a difference in your fight for safer, better staffed workplaces?
We wouldn't have safe ratios if we did not have a union. We passed this, I think it was 2009. We fought for it. We had to fight for it in our contract, and we won it. And then when we did win it, we went unit by unit with the managers to determine those ratios, because a chemo patient is vastly different than a telemetry patient, and you're hearing from all the different areas in regards to what those kind of ratios go by. If we didn't have a strong voice, if we didn't stand together, if we didn't stand up for our patients, we would not have it at all.
Thank you.
Thank you. Representative Piscatano.
Thank you, Mr. Chairman. Again, thank you to all the healthcare workers here today. We appreciate you taking your time. I'm sure you all had to take a day off to be here, and we do really appreciate it. You know, my mother's been a nurse, or was a nurse, for many decades at the bedside, and you know, that growing up that way and seeing the hard work that she did, you know, during her job before she had to come home and take care of her kids, really influences my work as a legislator. And I talk about this a lot, where we have these public sector professions in this country where people go in them as a calling. You know, no one becomes a bedside nurse to become rich or a millionaire or famous or any of those things. And nurses, teachers, police officers, firefighters, those folks go into that profession as a calling to help people and serve the public, and they do those things because that is what they want to, how they want to spend their lives. And too often we see that there are too many barriers that make it hard for people to do that, whether that's low pay or unsafe working conditions or ridiculous education requirements or, you know, barriers to practice, all kinds of stuff. And if we keep throwing those barriers up, or we don't tear those barriers down, fewer and fewer people are going to be able to answer that calling. And we will find ourselves in the situation that we see today, where we have shortages in pretty much all of those public sector careers. And so, again, I just want to thank you for the work that you guys do every single day, and for your willingness to take time out of your schedule to be here with us today. But I want to specifically talk to Ms. Mizell. I think she mentioned, and I just want to clarify a point, that UPMC cut travel nurse pay recently by, I think it was close to, I think you $13 an hour, which I think works out to about $20,000 a year. And you know, when we talk about workplace healthcare worker shortages, when we talk about you know, just the lack of bedside care available, ratios, all kinds of things. I mean, when you have significant cuts to pay, I assume that creates pretty big barriers to both employment and being able to stay at the bedside. You know, so I would just say, like, in the light of those recent cuts, has patient quality decreased, I presume?
There are nurses that have left for that reason. When someone cuts your pay rate that significantly with less than a month's notice, it's very challenging. They had no time to prepare. We were always told that our pay rate would remain the same, and we were blindsided and felt lied to when our rate was cut with less than a month's notice. I would imagine that with nurses leaving, that would create more holes in the system, which would then impact patient care.
And I think, I can't remember if it was you or another testifier that you mentioned how many nurses that have licensed nurses in Pennsylvania that don't actually practice medicine because of some of these barriers. I mean, I assume that a very large unexpected pay cut has led to people leaving the profession.
That's correct. I don't believe that there's necessarily, I think there's a shortage of nurses wanting to work at the bedside, not nurses in general. We don't feel appreciated, we don't feel valued, we don't feel heard. And we feel like our license is often on the line, and we feel like our patients' lives are on the line because staffing isn't appropriate and safe in the hospitals.
Well, God bless you all for what you do every day. Thank you.
Thank you.
Thank you. And I'd just like to thank you all for being here today. Your commitment to your patients and the profession is admirable. I look forward to working with all of you in the future as we get through this process to draft legislation that we hopefully can get through this committee and onto the floor. And again, I just want to thank you all for being here today. We're going to have the second panel come up. We are probably about 10 minutes away, 10, 12 minutes. So for the next panel, we're going to have Pat. We got Jeff online, and we're going to hear from both of those individuals, and then we're going to have some brief questions, and hopefully we can have it wrapped up by 11 o'clock. So thank you. Thank you. Okay. Well, Pat, whenever you're ready, you can go ahead and get started. Thank you.
Chair Dawkins and members of the committee, my name is Pat Garofalo, and I'm the Director of State and Local Policy at the American Economic Liberties Project, an organization dedicated to reducing the power that dominant corporations wield over our economy and democracy in pursuit of economic liberty for all. Thank you so much for the opportunity to testify on this very critical issue. I'm going to discuss the role corporate power and consolidation play in the healthcare workforce crisis in Pennsylvania and, in fact, all across the country. Like so many sectors of the economy, the healthcare industry has seen rapid consolidation in recent decades. According to many studies and ample real-world experience, which you've heard about here, that consolidation leads to negative outcomes for patients, healthcare workers, and broader communities, including higher costs, lower quality of care, less price transparency, and pertaining to today's hearing, lower wages and worse working conditions for employees, including nurses, doctors, and non-medical staff. For example, a 2021 study in the American Economic Review showed that 4 years after a hospital merger, wages are 6.8% lower for nurses and pharmacy workers and 4% lower for non-medical workers than they would have been if the merger had never occurred. A 2019 study published by the Washington Center for Equitable Growth found that mergers directly cause real wage growth for skilled hospital workers to slow by up to nearly 2%. This occurs because of what is known as monopsony power, which is the power of buyers, whether they be buyers of products or of labor, to drive down what they pay in the market as they consolidate and monopolize it. The Federal Trade Commission found in 1996, and federal courts later confirmed, that buyers with as little as 30% of a relevant market can put downward pressure on prices due to their monopsony power. In the context of the healthcare workforce, consolidation amongst employers has resulted in workers having fewer available options and therefore less leverage to negotiate for higher pay or better working conditions. In Pennsylvania, you've experienced this firsthand with the rapid growth of, for example, the University of Pittsburgh Medical Center. UPMC's stream of acquisitions in recent years have given it significant market power, as we detailed in a report last year titled Critical Condition: How UPMC's Monopoly Power Harms Workers and Patients. This concentration across the healthcare market gives UPMC considerable leverage over workers, which it wields to keep wages low, as you heard, unilaterally change wage levels with little notice, keep conditions unsatisfactory, and prevent union organizing. To that end, we're encouraged to see reports that the Department of Justice is investigating UPMC's power over workers, especially as it has proposed absorbing yet another healthcare system into its network in Washington Health. But state lawmakers also have a role to play in reining in not just UPMC's power, but the power of all dominant healthcare systems, to ensure that workers can receive just compensation for their vital work, as well as to slow and ultimately reverse the rampant consolidation the state has experienced across the healthcare industry. In our 2023 report, we made several suggestions to bolster the leverage held by workers, including but not limited to banning non-compete and training repayment debt agreements in the healthcare industry and enacting labor peace laws. We're particularly excited to see that the House Judiciary Committee recently approved Representative Nick Piscitano's Open Markets Act, which would do two critical things: create a state antitrust statute for Pennsylvania, which is currently one of the only states to lack its own state antitrust law, and create a notification regime for healthcare entities that wish to merge. These two provisions would give state antitrust enforcers key insights into the healthcare market that they currently lack, as many mergers fall below required reporting thresholds, as well as the powers to use state law to rein in consolidation that harms workers. We urge the full House to take up and pass that important measure. Thank you for your time, and I'm happy to answer any questions.
Thank you very much. Jeff, you're online. You can unmute yourself and you can proceed.
Good morning. I really appreciate the committee giving me this opportunity to testify this morning. So my name is Jeffrey Shook, and I'm professor of social work at the University of Pittsburgh and principal investigator of the Pittsburgh Wage Study. The Pittsburgh Wage Study began in 2016 as a mixed methods longitudinal study of hospital workers and other low-wage workers in Pittsburgh. As the study evolved, the study team observed that while wages were important to worker well-being, hospital workers also consistently discussed the impact of work conditions on their well-being. So we expanded our focus to include issues such as staffing, unsafe work conditions, and worker voice in decision-making. Key findings from a recent report from our study found that 93% of hospital workers were thinking about leaving the field at least once a month, and 37% were thinking about leaving daily. And unsafe staffing levels was a big contributor to individuals leaving the field. 73% of former hospital workers we surveyed cited staffing as a key issue in their decision to leave, as we've heard today from the nurses who've testified. As one nurse in our study reported, I worked in multiple different hospitals across the city. Every single one was the same: not enough staff and continued increase of expectations while grossly unstaffed. Unsafe staffing has also placed many additional pressures on workers and patients. Many reported feeling pressured to work overtime, not having meals or breaks during their shifts, performing tasks outside their job, and the high physical and mental toll of high caseloads. As one nurse stated, people don't know out there like how bad it really is. They don't know when they come to the hospital how dangerous it could possibly be because of staffing levels. Low pay and unsafe staffing have contributed to high rates of mental health issues among Pittsburgh hospital workers, including depression, anxiety, trauma, and even suicidal ideation. A nurse summed up their experience. Every day that you walk in that hospital, you feel like you're walking into chopper blades every day. There are no good days. Hospital workers also reported that they received little support or help with mental health challenges from management and the hospital systems they work for. Workers also continually express that the challenges they face are exasperated by their lack of voice in decision making. One worker said, "I think the biggest problem with working for a conglomerate like UPMC is the automatic kind of thought that you are a robot and that you cannot be trusted. You don't get to make decisions for yourself or your patients because it's bill, bill, bill. We need to make money." Many of the nurses and other hospital workers we have talked with have real ideas for solutions to address the issues they face, but they have no voice in decision making, and these ideas often go unheard. Through our study, we have talked to so many committed and dedicated hospital workers. In Pittsburgh, where I live and work, they've really become the backbone of our city. I appreciate the committee listening to my testimony and working to find real solutions to better support our hospital workers. We have to do better. Thank you.
Thank you. Does any of the committee members have any questions? Well, seeing none, I just want to thank all of you testifiers for being here today and providing us with this valuable information. And I want to, again, let folks know that this is the process in which we go through to kind of gain this insight so we can actually have informed legislation as we move forward. So with that, I thank you all, and I think we're going to go ahead and adjourn this informational hearing, and thank you all.